discuss pertaining to, the hi-fi stuff, which is your transpulmonary pressures, which you have already seen. I'm not an expert in cardiopulmonary ventilation either. I'm just going to help you in understanding that how you can integrate the basics to the advance, which we have been talking in this presentation, right? And how, when you integrate, you can achieve actually the bedside clinical, the excellence for your patient. And of course, it's a panel discussion. We have already named the panels, but this discussion is open to each one of you. Whosoever would like to participate, please feel free to share your views. As I said, I'm not an expert in PPP or either CPP. However, my intention is to define the best possible interaction between the man and a machine and possibly the outcome in favor of our beloved patient, right? I'm going to start this panel discussion with the help of this case. So it's a 26-year-old male, not having any comorbidities. He came to us with fever, cough, shortness of breath for the last 1 week. He was tachypnic at the time of presentation. He was using exercise muscles. And if you can see, the sacs were just 88% on 15 liter of oxygen through the non-rebreathing mask. His GCS was running low. And in the pre-intubation, the ABG was suggestive of severe acidosis, mainly the respiratory acidosis, also complicated by the lactic acidosis. So obviously, these kind of cases, they need intubation. The patient was intubated in the ER in view of the low GCS and worsening of the respiratory failure. The patient was initiated on 100% FiO2 to begin with. The tidal volume was given 10 mL per kg, which is around 500. The respiratory rate was 20 p per 5 and I ratio 1:2 to begin with. His SATs were 94% on FiO2 of 100% on CMV. PF ratio, obviously you can see that it is less than 100. He was tachycardic and hypotensive, right? And you can see the X-ray which is visible on your right. Now I would like to ask any one of you, what do you think your concerns are in this case? And what do you think is the best possible working diagnosis? Any one of you in the panel? Do we have a mic for that, please? Dr. Ankit, would you like to opine? This is better. A lot of distance is there between you and us.
Yeah, by looking at the parameters and GCS and other parameters, we can think it is a case of probably pneumonia with on the right side there is a cross effusion we can make out. So maybe it's like pleural, like we can call it as pneumonic effusion with pneumonia, bronchopneumonia with the respiratory failure.
Of course. Anybody who would like to add anything extra? What about the severity of hypoxia, which you can see on this basis? What do you, maybe Dr. Sharma?
Definitely what Dr. Ankit has said, that there is some effusion on the right side. We'll just go back to show me the X-ray, previous slide. There is opposite and bilateral opposite on both, all over the lung field, more on the left and the right side. So maybe Pneumonia pneumonitis both all over the lung field. And definitely pneumonia, bilateral pneumonia, maybe going to ARDS. Kind of picture. Patient severe respiratory distress, respiratory of 36 per minute, huge of accessory muscles, the hypoxic, which hypercapnic, the acidotic, maybe severe pneumonia and with some effusion on the right side and bilateral opacity going to ARDS.
I agree with you, sir, because this is what, majority of the time when the patient is severely hypoxemic, we also think, the ARDS is one of the first differential, which could be a sequelae related to pneumonia, as you have said. But do you really feel the opacities are bilateral? What do you think? I don't know why we always have a difference of opinion, Dr. Sharma. Last case discussion also, if you remember, when we had in, the Sharda hospital, there also we had it. So he, his opinion is always different from my opinion. I don't know why. But anyway,
more on the left side, definitely for right side.
Okay. So, but for sure, the patient is having a cap. There's no doubt at all. Maybe you can say there is a difference opinion with respect to the bilateral shadows on the basal X-ray. And of course, the things are looking different on this projector when I saw this thing onto the real X-ray. So, the contrast and exposure makes a lot of difference. So, as you have said, Dr. Sharma and Dr. Ankit has said, Yes, the patient was having a cap. Obviously, it looks like the patient is having a pneumonic effusion. You can see meniscus sign. And the patient, on the basis of PF ratio, it's a severe hypoxemic respiratory failure, right? And the patient was having a septic shock. ARDS, let's see that whether this patient is actually having an ARDS. And what do you think, Dr. Anil, when you have this kind of a case, how do you resuscitate in your ICU?
Basically, considering the vitals of the patient, and we have already intubated this patient, considering the hemodynamic compromise as well as the hypoxemia, which is very evident with the PF ratio less than 100. So basically, initially we give fluid boluses, not much because we have to balance. We have a lot of tools which you can utilize for having a fair idea about the fluid status or the fluid volume, as well as ultrasound chest will also guide you about the resuscitation practices. Lactate is also going to guide you. And appropriate initiation of vasopressors. Appropriate.
No, it's working. You just have to keep it close.
So appropriate initiation of the antibiotic plan, considering this patient is of CAP, then appropriately we have to start a good antibiotic.
So the initial fluid bolus, we all agree 30 ml per kg as per
So I really don't agree with 30
So you
ml.
don't agree. Why?
So I think every physiology, every patient does not require 30 ml per kg body.
To begin with, we are talking about, let's say this patient is coming to you in the night and your resident is there. The patient is coming who is hypoxemic, but yes, at the same time the patient is crashing because of the blood pressure.
Probably over years
So
of
what do you do?
experience and the current evidence, fluid resuscitation definitely is the role, but probably 30 ml per kg could be little higher volume, especially considering the kind of ARDS picture, hypoxemic failure which we are looking at. I agree.
So I think
there is a hemodynamic compromise, but it does not mean you give 30 ml per kg.
I think it's a very valid point, Dr. Anil, what you have raised, that every patient who is coming should not be given the 30 ml per kg as an empirical fluid challenge. But do we have any different guidelines which endorse different volumes? Dr. Sumira, what is your take? Because, it's an experience based what we are speaking, but what about the endorsement which we have from, the guidelines?
Good evening, everyone. So my opinion, I would just say, would slightly differ from Dr. Anil. I won't say that these guidelines have been actually published for each and every individual patient. It's just, majority of the times when you receive a patient, this is the initial one, when you receive it in an emergency setting. You have a patient who is quite hemodynamically unstable, who you have just intubated. 30 mils per kg looks very big, but if you just have 50 kg person, it comes out to 1.5, and you're not giving this 1.5 just in 15 minutes. You're giving the 500 ml, you're watching your patient, you're giving another 500 ml. So I think it's not about the number that should be focused, it's about how you achieve this number. The same person giving this 1.5 liters in 15 minutes and the same 1.5 liter going around about 45 minutes, I think this also makes a difference. So completely saying that no, 30 ml is not the right number, 15 ml is, I don't think that it's only about the number, but it's also about how you actually approach the patient. Because number of times when we receive the patient in ICU, the gap from emergency to ICU is more than 8 hours. It's sometimes 12 hours. So many a time we feel that the patient has been too underhydrated, and then you land it up into pre-renal AK and everything. So for me, I would say that it's not only about the number, it's also about how you approach this number and how you get about it.
That's an extraordinary effort, Dr. Sumira, from your side. But idea is very, the reason why I'm asking this, because when you have a patient who is crashing because of hypoxemia, who's crashing because of hypoperfusion, the initial resuscitation has to be as simple as possible. You cannot complicate in terms of whether it has to be 10 ml, 15. Now the reason why I'm saying it, because this is based on some kind of a guidelines. Now we may differ as far as the working policy or the guideline is considered, but then there has to be an endorsement, right? There has to be some sort of a recommendation. So, but yes, I do agree, because Dr. Sharma is also here. He also believes in conservative fluid strategy, and now, in fact, the papers from Monet and Tebul, they are coming up where they are saying that 30 mils per kg should not be the initial choice of a resuscitation, especially when you have a leaky lung, right? So they're talking about 50 mils per kg, but yet to have any guidelines as far as this thing is considered. But let's go on to the second part. Obviously, the patient received the norepinephrine, which we do. The patient was given empirical antibiotics, lactate, and cultures were sent. Now, I would like to know from Dr. Ankita. You understand the patient, right, Ankita? So, what do you think you have the chain of concerns when you are having this kind of a patient in your ICU?
Am I audible?
To me, you will be.
Somehow I feel after so much of discussion also, and the thing which is haunting me is the case which you had presented. There are still many loopholes in that.
Yeah.
I somehow feel my head is going towards that. Is it the septicemia which landed up in such a condition? I mean, right, patient, because he's too young. He's just 26 years old. He's having fever and cough. Maybe he was having some, I would say, he has taken some infection from somewhere, and then his symptoms came into picture. So the X-ray, definitely it is pneumonia, pneumonitis, even you can say fluid overload also. Has that come from some other organ which we are not catering to? So in this, my concern, definitely hypoxemia is there, but my more challenge is into fluids. Because until and unless if I would not keep his circulation in hand, I don't think that I can achieve even his oxygenation also.
So,
That is what I
no, Ankita, your points are very valid, but just imagine, Dr. Bhalla, the people who are well expert in the subject having so much of confusion in the ground. What happens to the people who are otherwise resuscitating them, who are actually beginners in the subject? Because majority of the time, the people who are resuscitating them, they are the beginners in the subject who are available at that time. The kind of a confusion which we are having, right? Yeah, please, would you like to say something?
This confusion will persist till we are alive for next 1,000 years. But let me tell you the important thing in a resuscitation like this, which I wanted to make before giving for the fluid, is to insert a CP line immediately and follow the rule of 2 and 5 and 3 and 7. 2 and 5. So this business of volume whichever 30 ml kilogram stat known, go with aliquots of 50, 100 to 100 and watch the CVP rise. That should be the, and there's no argument about that. The sine qua non of fluid resuscitation in a patient in ICU with a bad lung is a CVP. That's very important.
Sir, actually, nowadays the latest, of course, guidelines are not guidelines, but CVP monitoring is not mandatory, especially in these critical areas. The first line of resuscitation we can very well assess with the help of collapsibility of IVC. That is one thing, and then the second thing is IVC, this capillary refilling time. So those are
Anything to assess the volume currently present in this thing.
and whatever. And first and the foremost thing which every one of us should remember is that giving a fluid challenge and seeing the response to that fluid challenge is the first and the foremost thing that we should.
So I agree with both of you. There is a reason why, because one school of thought, especially the old school of thought, still believes in titrating the fluid with the CVP and all. And as Dr. Kapil said, now the recent recommendation is to follow the fluid responsiveness trial, and on the basis of that fluid responsiveness, you decide that what the patient deserves to be, right? So, but Manjul, what do you think your concerns are? Because Ankita said something. What do you think your concerns are when you are dealing with this kind of a patient who has been hypoxemic, hypercarbic? So what are they?
Sir, first of all, my concerns, as we have already mentioned, the patient is severely hypoxemic. The second concern will be the that whatever the fluid we are giving, the resuscitation, whatever we are doing, what is going to be the harm to the organs. Then third will be whether our ventilator strategies, what we have initiated, whether they are appropriate or not. Like initially we have given the 10 ml per kg. So that should be 6 to 8 ml nowadays what we.
So let's come back to the basics. I agree with you that we can always redefine the challenge, the volume which we have to give. But the basic concerns when you're dealing with this kind of a case is one, as you can see on the slide, patient is severely hypoxemic. patient is hypercarbic. So obviously you need to have something to take care of hypoxemia and hypercarbia. Your ventilation strategy has to target this one, right? The third, as Dr. Sharma also said, on the basis of what we have seen, is it actually an ARDS or is it not an ARDS? Because a lot of things depends upon what is your working diagnosis, right? And should I give low tidal volume if it is an ARDS? Yes, but if it is not an ARDS, Dr. Sharma, in that situation, what should be my volume strategy when you are trying to ventilate them, right? And obviously, we have been talking about the airway profiling, which we have seen and we have listened in the last two sessions, especially the transpulmonary pressures. But before TPP comes, I say it's a very advanced, but the basic airway pressure profiling, which means your peak airway pressures, plateau airway pressures, they have to be seen, right? And obviously, septic shock is a big concern because when you're using PEEP, when you're using volume, you have to see that it should not be hampering the patient hemodynamics, right? So these are the basic concerns, right? So Dr. Sharma, on the basis of this thing, your proposition is that we are dealing with ARDS, right?
Yeah. It's a maybe severe CAP may go to ARDS very soon, and depending on what kind of antisetting we give to this patient. If we get tidal volume like this 500 ml, which is fairly high volume for this patient, I will say. Ideally, I would give about 6 ml or 6 to 8 ml maximum per kg, ideally 6 ml per kg body weight tidal volume to the patient. If you initially 100%, I feel agree.
Thank you, sir.
A rate maybe on the higher side, rate of 25 to 30 rate to maintain tide, come down to hypercapnia, and to keep the peak pressures limit up to 30, and plateau pressure 20-25. Try to keep the lower pressures to limit the ventilator-induced lung injury. That is our aim, should be.
I think, that's perfect. But how many in the house they believe it's an ARDS? Please raise your hands up on the basis of what we have given. This is always a debate, sir, and we love it. And what about how many people they don't believe it's an ARDS? And what about the people who are not doing anything? In between? So they are trying to understand whether it's an arts or no arts. Now this is what actually happens in real grounds. When the patient comes, a lot of confusion happens. You don't know whether it's an arts or not arts. But having said so, let's say it's not an ARDS. What should be your ventilation strategy? It's not an ARDS. What is your ventilation strategy, Dr. Ankit or Dr. Sharma?
Even then, I will use a low tidal volume ventilation, even if it is not an ARDS.
So it really doesn't matter as per your understanding. You have to give them low tidal volume.
Yes, low tidal volume.
What about you, Dr. Sumera?
I think that what do you define as a low tidal volume in ARDS is definitely different from what you otherwise see. So I personally, when I do the ventilator settings, I don't just really look for tidal volume. I also look how the patient behaves in terms of P-plat and how does the patient behave in other parameters. But
we will talk about P-plat. Just to simplify, what should be your initial?
I start initially with 8 mils.
Now, Dr. Balla is from the old times because I am sure he must be using 12 mils per kg in your time.
No, that's true.
Yeah,
in our time, it was 10 ml per kg.
12?
Then 10.
Okay.
But by the time I retired, it had come down to 6 to 8 ml per
So
kg.
now 6 to 8.
Now
Now
6 to 8.
the question, why I'm asking
But
this?
but there's a rider there. It all depends on the P-plat, as she mentioned that.
So we will come to P-plat. We will come because I have to just go forward in this case discussion.
6 to 8 ml.
So 6 to 8 ml. So it really doesn't matter whether it's an arts or no arts?
No, it doesn't matter.
Doesn't matter.
Doesn't.
How many of the people in the house they believe it has to be always low tidal volume, irrespective of arts or no arts? Whether you're dealing with normal lungs, healthy lungs, diseased lungs, how many of you believe? Good numbers. And how many of you believe no, if it is not arts, you give around 8 to 10 ml per kg, which is a good tidal volume? No one? Okay. Now there is something interesting which Dr. Sharma has already raised it. Now this is basically from the Agency of Healthcare Research and Quality, which is one of the 12th agency in the US FDA, right? And what they have said, that low tidal volume has to be implemented for all, irrespective of whether it's an arts or no arts. Now why I'm telling you, because the safest thing and the first most thing which you're going to do when you're going to set the ventilation is the tidal volume. So rather than talking about TPV, which eventually you have to do, But first talk about the tidal volume, what you're going to say, right? So it has to be. Now the reason what they have given is very, very interesting. You know, Dr. Kapil, what they have said, low tidal volume can actually reduce and prevent ARDS progression in patients without ARDS. So even if it is not ARDS, but the chances of developing ARDS will be substantially reduced. Second, high tidal volume contributes to lung injury in patient even without ALI at the onset of mechanical ventilation. Even if your lungs are healthy and you're giving them high tidal volume, you can expect that the patient will develop ARDS because of you, right? This is something which is alarming. Low tidal volume means lower risk of development of pulmonary complication in patients even without ARDS, like pneumothorax and all those complications. In patients with healthy lungs, all those people who are working in operation theaters, what they have been talking about, this low tidal volume also has to be extrapolated to the operative settings. But there they have to combine with moderate PEEP along with the recruitment maneuvers in order to give them the morbidity benefit. So use of low tidal volume has to be considered in all mechanically ventilated patients regardless of ALI. Sir, पहले से ही था.
Sorry? It is not that it is settled.
Yeah.
I am saying that debate is not yet settled. It will go on. It is almost see, after 5 years we will. What I am saying that it is not that that debate is settled. After 5 years we will find out something else. So be prepared for that.
And this is, this is what we love about the evidence-based medicine. Today, what you prove 5 years down the line looks very funny. So, but anyhow, we have to sort it out the prices of 2024. So we have no other option to use the time.
Just to verify what you said, we must go back to the lung physiology. There is an effect known as Lorentz-Smith effect. How many people know about it? That the moment you start oxygenation in a patient, even with 50% oxygen, 40% oxygen, at even the lowest pressures, lung damage starts. So if you start with a high volume, the lung damage will start within the very first minute.
Yeah.
And as you have rightly shown, that the chances of progressing to ARDS will increase. That's why, as Kapil has mentioned, but I believe at the moment the argument for low tidal volume between 6 to 8 ml, some people in fact say 5 to 7 ml is when you have a patient as Ramurthy has seen in this, we should start and then as Sumera said, we see the P-plat and then change the thing. But the first sitting on the ventilator should be in 60 ml.
No, that's
and that goes to the Lorentz-Smith effect. You can look it up on the Google. Two effects, Lorentz-Smith and the forward effect.
Yeah, it's given in your Ganons. So right from the basics. Thank you, sir. Yeah, no, that's good, sir. Hands off to you. Yeah, please.
Actually, now I think it's become very obvious that every ventilation starts with 6 to 8 because if you see the arts which started, where it compared with the high tidal volume versus low tidal volume, they started it with 10 to 12 coming down. So I think now it's become synonymous with 6 to 8. So now the debate is from 6 to 8 to coming down to 4 to 6.
Yeah. No, when we are sitting and discussing over a tea, coffee or a drink, everybody speaks 6 ml, 8 ml. But the funny part is that if you see the evidence, less than 30% of the people worldwide, they are actually using low tidal volume. Now this is from the evidence-based medicine. Less than 30%. I'm not talking about this country. I'm talking about bad continents. So despite of understanding that low tidal volume is mandatory for your patients who is being initiated on mechanical ventilation, still there is no adherence to this policy. That is where. What about your experience, Ricardo? Do everybody is giving low tidal volume over there? I know you are in, one of the best centers, but still.
Actually, in the end of my time in Brazil, yes, everyone, we put in the table on there is a white table from each patient, and we put there 6 minutes per weight, and everyone follows it.
That's beautiful. Thank you, Ricardo. Now the question comes. So, Dr. Sumera, and in fact, Dr. Ankit, now I will ask you. We know that we have to give low tidal volume. Now, my question remains the same. Let's say the people who are sitting in the back, especially who have to handle the patient all alone. How do you initiate ventilation? You know that it's a possibility of an ARDS, yet not arts possibility, as Dr. Sharma has said. What should be your ventilation strategy to begin with?
As we have discussed that patient is extremely hypoxemic, so we begin with those 6 to 8 ml per kg of body weight, and as we have seen that patient is PCOT is on the higher side, so patient is still like most of the dead space ventilation is there. So just to reduce the mechanical dead space ventilation, we can remove the dead space by removing the cap mount or mechanical dead space and directly connect so that the dead space can be removed and we can achieve the oxygenation better. So just to begin with, tidal volume of 6 to 8 ml per kg and
Alcohol volume कम होगा.
Sorry, sir.
Alcohol volume कम होगा.
You need more alcohol, sir, to give tidal volume? Your tidal volume is running good. So, as you said, Ankit, you know,
if I were to should begin with 100% if I were to, tidal volume 6 to 8 ml per kg may be around 400.
Just to add, you know, because in the interest of time, Dr. Bella, they have given a very interesting strategy which has got published in 2013, and especially for all the people who are novice in handling the sick patients. What they have said, the first thing is to make sure that all the patients, they receive lung protective ventilation. That is very clear. So which means you will give 6 to 8 ml per kg and make sure your plate UV pressure is less than 25, as Dr. Sumira has said, right? So you have to prevent volume trauma. Rate has to be adjusted as per the time constant. If you feel that the patient is having air trapping, they have to be given more expiratory time, you have to reduce the rate. In case if there's no air trapping, you have to increase the minute ventilation for the dead space which is open, right? And you have to set the beam always and always more than 5, because you have to take care of the recruitment of the lung, which is likely.
No use below 5.
Yeah, no use below the 5. Permissive hypoxemia, 88 to 95. I don't know why the people, they keep more than 96, 98 in their ICU. Everybody loves it. But somehow 88 is a magical figure now.
90%.
Yeah, yeah. And make sure that there is no asynchrony. And if the patient is at risk for ARDS, which you discover later on when the patient is staying with you, make sure that the patient receive deep sedation to short-term neuromuscular blockade to improve the V-vacuum mismatch and to prevent ventilator-induced lung injury. And higher peak in case if the patient is requiring a higher FiO2, right? Now, when we had this case, Dr. Sharma, I think you were sitting on the 4th floor, I was sitting on the 2nd floor, so sorting out this, because sir is MS, you know. So this case, when we were trying to sort it out, Dr. Ankit did the ultrasound, and what he discovered, what you said.
That's another thing I have mentioned. That the moment patient comes in, ultrasound should be done in every patient.
Yeah, so we did.
Absolutely.
No, we did, sir, but we took some time because it came at the odd time, this patient. So when Ankit did the lung ultrasound, as Dr. Sharma said, the right side of the lung was having a significant effusion. It was a transudate because there is no fibrin deposits which can be seen. Plus, there is collapse and consolidation. You can see static dynamic air bronchograms, static mainly, right? Even in the left lung, you can see fractal sign. So which you were talking about, Dr. Sharma, on the X-ray, my impression was different, but when he did the lung ultrasound, it changed to your opinion that yes, we are dealing with ARDS. So this is how the availability of the lung ultrasound has changed the definition of ARDS in the 2023, right? Previously it was not there, and that is why we endorse, we recommend, wherever you have a suspicion of ARDS and you cannot find the findings of bilateral heterogeneous opacities on X-ray, you should confirm with the lung ultrasound. Yeah, please, Doctor.
But nowadays, control diagnosis of ARDS?
Yeah.
Ultrasound?
I will
Your
show you.
definition?
Yeah, I will show you.
Not
Actually, I deliberately skipped because, yeah, this one is the definition. So, ARDS New Global Definition 2023. Time of installation of disease remain the same. Pulmonary edema, yes, it has to be non-cardiogenic. Radiological features, infiltrates on X-ray, CT, or lung USG by trained professional, which is not explained by nodules, effusion, or atelectasis. PF ratio remain the same. For the developing countries and the under-resourced settings, even SpO2 by FiO2 ratio is sufficient. You do not need PO2F by FiO2 ratio, right?
Lung ultrasound can be used nowadays.
It should be used.
Complementary or supplementary.
Yeah, I'm doing fellowship in ultrasonography. Right? So that's where the patient was placed. Now this was the airway pressures. Ankit, what do you think? When we saw this patient, the airway pressures, because Dr. Sumira said, I would like to see the airway pressures. And I want to titrate my tidal volume depending upon the airway pressures. Now here is your magical numbers. The airway pressure is 45 peak, plant is 36, and dynamic pressure, your driving pressure is 26. You can see the ventilation settings, right? And this is your X-ray. How will you troubleshoot this pressure findings? Maybe Dr. Bhalla, Dr. Kapil, anybody who's handling this, the complicated numbers.
Normally, when the peak pressures are on the higher side, so usually we used to see for the mechanical causes, is it a kinking of the tube or is it some secretions or resistance, whatever the resistance coming on the mechanical side. So we used to suction the tube and we have to do the aggressive suctioning lavage so that we can reduce the pressures.
Yeah.
So this is the non-common, or when the right side is effusion is showing, we used to right lateral position we used to tell the patient to improve the oxidation of the patient.
Very important point. Even if you are suspecting ARDS, don't think that the patient ARDS cannot be complicated by the tube kinking, because
Yes.
plugs, they all can happen in a simple ARDS as well, right?
Yes.
So you have to see about all those problems of resistance, especially when the peak airway pressures are high, right? Because the patient has both rise in the peak as well as the plant, right? So you should also look about the compliance issues.
Yes.
Obviously, patient is having an ARDS, but because the peak airway pressure is out of the proportion to the plant, you must think about issues related to airway resistance. Just imagine, we are talking about the compliance issues, and the things get complicated by the airway resistance issue. This is how, the things that get happen when your patient is in ICU, right? So what intervention will you do? You, let's say you have these numbers, what interventions you do in your ICU?
So in our ICU, we have to look for the both intraluminal causes and extraluminal causes.
Very nice.
So intraluminal causes, as we are doing bronchoscopy in our ICU. So as you
Don't say bronchoscopy, people are going to kill us. This patient has to earn bronchoscopy. It is there, but let the patient to earn the bronchoscopy.
So initially the conventional method, what we used to do, that suctioning, kicking of the tube, after taking care of all the things, we saw that first of all I trained that effusion was there in the right side of the lungs. So around 700 ml of extraluminal fluid that I have taken it out to remove the oxygenation, and as well as intraluminal just to remove the secretions, mucus plug, as we have done the bronchoscopy in this patient. So after doing this suction and appropriate, because we are doing it as a diagnostic purpose, diagnostic as well as therapeutic purpose. So in both the cases, intraluminal, extraluminal, we have removed the mucus plug secretions, and extraluminal fluid has been extracted out.
Thank
So
you.
in both the
Thank you.
ways,
Thank
we
you.
have
Thank you,
removed
Ankit.
the
I think you have said almost every point, but Dr. Sharma, if you find your patient to have both rise in the peak and plant, will you do the same or you will have a difference? It's almost the same.
Almost same, plus you have done the sedation paralysis and
Yeah.
sedation, that also
Yeah, very
you can
good.
do sedate the patient, paralyze the patient. That will also control the airway pressure, peak airway
So
pressure.
I think it's a very valid
We
point.
should do
You have to make sure, apart from the disease-related issues, it's a patient finding which can also lead to so much of
High pressures.
high pressures, right? Obviously, there are certain indices which you can see on ventilator like stress index. In the interest of time, I'm not raising it. But do you think it is important to see about air trapping in ARDS patient? What is your take, Dr. Balla? Do you see for air trapping in case if the patient is having an ARDS ventilation? So, what is the rationale?
Rationale is because air trapping increases the influx massive pressure, and in the response to that, you will increase the driving pressure and you will hasten the lung damage. So watching the air trapping pressure is very important, because that's where it's going to tell us about the peak plant driving pressure. So I think that's a very important component of management.
So air trapping has to be said. What about you, Dr. Sunita?
Well, I think most of the things is already explained. Obviously, air trapping is...
Auto-peep we are talking
yeah,
about.
we are talking about the auto-peep. So obviously, because that is indirectly going to contribute to your pressures. And if it is there, then obviously measures have to be taken care of.
So there is something which I want to highlight for the people here. When you are ventilating an ARDS patient, you typically give more time for the inspiration and you give less time for the expiration. You actually induce auto-peep in there. Now, let's say if a patient is having already a COPD kind of a lung, they already have a predisposition for air trapping, and plus you are giving them less expiratory time. So it's very important to study the patient lung when you are trying to ventilate an ARDS patient, because somewhere you are also inducing air trapping in them. Because you are keeping a rate on the high side, You give more inspiration and you give less expiration, right? But it doesn't happen per se. Why? Because they have relatively fast time constant. We will discuss this thing somewhere in the later part. Now, because the patient was having, sir, थोड़ा सा तो बैठो, पीने के बाद बिल्कुल अलग हो गए. उससे पहले you were participating long. हाँ? Sorry? Sir, please. So, basically, when the patient was having high B-flat AV pressures, peak AV pressures, apart from what Dr. Ankit has said, there was an obvious reason. The patient was having a pleural effusion. And that is why the therapeutic pleurosynthesis was done, draining almost 1,000 mils, right? Which actually has led to the improvement in your AV pressures. So not everything which is difficult to ventilate is purely an ARDS. Things do get complicated by effusion, collapse, consolidation, atelectasis. Always you remember, right? Now, driving pressure is important to be assessed in them. I think Ricardo has already spoken about the Amato meta-analysis 2015, which was a benchmark, which has said that peak AV pressures, plateau AV pressures, they are not the most important AV pressures. The most important AV pressures remains the driving pressures. Why? Because plateau AV pressure, they does get affected by the extra thoracic factors. For example, obesity. For example, abdominal effusion. For example, pleural effusion. So you need more reliable pressures to be there. So driving pressures has been found to be the most important determinant which can predict the mortality of your patient and keep it less than 14 for them, right? This already is spoken about. This is what I was talking about. But even the driving pressure has a limitation. Because the driving pressure is what? Plateau AV pressures minus peak. And the plateau already has a confounding variables, right? But DP is more reliable than just estimating the plateau AV pressures, right? So these are all the factors which are going to affect your patient assessment. Now the question comes, we are having this session on TPP, right? So transpulmonary pressures, where do the transpulmonary pressure is placed and in what cases should you be using? Now there is a simple format which is available, Dr. Balla, and we have started using it. You begin with 6 to 9 ml per kg. First pressure which you have to see when the patient is on mechanical ventilation is driving pressure, not plant. And if you find that driving pressure is more than 14, which is taken as a cutoff, you should exclude the reason for which can lead to the factitious rise in the driving pressure, like morbid obesity, abdominal hypertension, worsening hypoxemia. So if you are having a patient in your ICU who has pleural effusion, massive, abdominal obesity, has massive pleural effusion, obesity, insufflation, trindle bucket, these kind of cases, DP is not reliable. Now these are the cases where you should use esophageal balloon and monitor the TPP, right? Because the question comes, TPP is something, I won't say invasive, but it's not easily accessible. So in what subset of population you are going to use it? Majority of the kind, driving pressure does the justice. But if you have high risk condition which can confound your driving pressures, you should consider in monitoring the TPP, right? Somehow it is not happening, sir. I don't know why. Is it available in this country? Anybody is using? No. In this country, anybody is using TPP. So it was there in the past, it has been taken off. That's why I'm telling you. No, it's not available as per my understanding. It's not available right now. So anyway, the PF ratio continues to be less than 150. What you do in case if the patient is persistently hypoxemic, we saw air pressures, you did pleurosynthesis, you optimize the feed, driving pressures, they're still on the high side. How do you recruit them?
So for recruitment, we used to give high PEEP to the patient, and still just for prone ventilation, we used to initiate the patient.
So the point is that in case if you find the patient is persistently hypoxemic in the past, it's a real patient. So in case if you find the patient is persistently hypoxemic, rather than doing any specific recruitment maneuvers, RM, you should use more of prone ventilation, which itself is a recruitment maneuver, right? We did, right, based on the Prosever trial. Still, after the proning, the patient AV pressures were on the high side, but driving pressure were reduced from 22 to 18. What will you do in this situation? Ajul, or maybe Dr. Kapil.
I would like to go for the second cycle of the proning.
Okay, so we will continue, but there is hypoxemia has got better, but what is anybody, Ankita, what will you do? but patient airway pressures are high. It's not giving you the benefit in terms of what you want to obtain. See, proning means your patient should change in terms of the recruitment of the lung. There is some improvement which has got happened, but not the complete resolution. Still the DP, driving pressure, is beyond 14, which means the patient is still having ongoing ventilator-induced lung injury. What do you think, Dr. Sharma?
If we can reduce the tidal volume further, that can be.
So that's very good. So you can further consider reducing, provided that hypoxemia is not worsening and hypercarbia is acceptable. ECMO is one. What else? Can you see the peak airway pressure are still on the high side?
Still continue.
Yeah, who said you? Yeah, we have to continue. I'm not denying proning, but proning is not helping you in terms of the targets which you want to achieve.
Superadded infections we have to look for. Any superadded infections.
Intermittent nebulization, because sir believe there is a hyper constriction. What do you think, Subira?
I think if after proning and these things continue, then go back to your basics. Check again for the same causes which you already have seen, and look for any possibility of mucus plugging or any other such thing. So I think going back to the basics and
Very
checking.
important, very important. See, when you're handling the patient, the man and the machine, don't forget the disease, please. You know, there is interesting numbers which you're seeing it. But remember, the numbers are not improving, not purely because of the ventilation issues, which is purely mechanical. There is a disease which is persistent, right? So you have to go about that why my patient is not responding. Maybe the patient choice of antimicrobials has to be revisited. Maybe the patient has some different pathogens, right? Don't forget the complications which are likely to happen with such an extensive lung disease, where bronchial obstruction, lung abscess, and pyma effusion can happen, right? So what we did, which we love, whenever we have a diagnostic dilemma, so Dr. Kapil, in those situations, whenever we have a diagnostic dilemma, airway pressures are very prettily rough, we actually do a point of care of ICU bronchoscopy, and this is what we discovered. The patient was having extensive bloody secretions. The moment we did, there was a resolution in terms of airway pressures, flat and driving pressures. So not everything is going to be taken care of with the help of proning. You have to do proning. I'm not denying proning, but proning is not the solution when first proning is not giving you the desirable response. See it in this term, right? And this was the X-ray after doing the proning 2 cycles, bronchoalveolar lavage and pleurocentesis. 3 things were done, and you can see there is a significant resolution in terms of the X-ray findings, right? So not everything which is difficult to oxygenate or ventilate is purely ARDS. We are saying definitely the patient has an ARDS, but every ARDS can get complicated by mucus flux, atelectasis, collapse, and consolidation, which forms a major fraction of hypoxemia and the complex airway pressures which you witness onto the monitor, right? So this was a patient. This is today's morning patient status. PF ratio improved to 256. Spontaneous awakening trial was given. Spontaneous breathing trial was given. And this patient, you can see.
ठीक हो जीभ बाहर निकालो अपनी पहले से आराम लग रहा है अब कोई दिक्कत सांस लेने में ज़्यादा दिक्कत तो नहीं हो रही हो जाओगे ठीक है ना भरोसा रखो
So now you can see that the patient has started responding. PF ratio is 256, which was less than 150, right? Patient is on FiO2 of 40%. You can see the stable vitals. Patient was having a shock, now is getting off from the vasopressors, and the patient is ready for the extubation, right? So transpulmonary pressure, already Ricardo has spoken. I'm not going to touch over it, but remember this thing, you know, whenever you have a complicated lung who has an ARDS, where the things has the confounding variables in the form of obesity, abdominal effusion, ascites, pregnancy, patients who are placed in the ventricular tilt. Now those kind of cases you should consider for the transesophageal pressure, because driving pressure is a reflection of respiratory system compliance, which means both the lungs and the thoracic wall. So any factor which will affect the thoracic wall will also affect the driving pressures. While TPP is exclusively dedicated for the lungs, right? I don't think this video is... So anyway, carry-on message is low tidal volume is for all. Low tidal volume and high PEEP and low plateau wave pressures, which used to be known as lung protective, is not entirely lung protective unless and until you do the TP with them. right? Know the limitation of plateau pressure and driving pressures, where the TPP can be the edge. Driving pressure is a reflection of entire respiratory system compliance, right? Persistent high driving pressures and plateau in a selected patient warrants TPP guided ventilation therapy. Not everything which is difficult to ventilate is ours. I still feel, and I always say, ARDS is possibly a man-made disease. At least it gets worsened in the presence of illegitimate ventilation strategies. Initiation of ventilation itself is a trigger for ARDS in predisposed weddings. And primum non-nocere, first do no harm. I think that's all. Thank you from my side. Thank you for taking your time. I know it was a rush, but